Hi, Kylie Moss here with the Center for Vulvovaginal Disorders. I'm here with Dr. Melissa Mauskar, a wonderful dermatologist who's talking with us today about conditions that cause itch. And we talked a lot about anatomy and background on itching in the first segment. And then we talked about things that cause vaginal itching and that the vaginal itching can affect the vulva. Now we're going to focus a little bit on the vulva itself. So the vulva, and Dr. Mauskar has an amazing puppet, a vulvar puppet that can help us out. But we have, the vulva is the external genitalia. It's what you can see with your
Where
eye.
all the good stuff, all the good stuff is.
Yeah, it's where all the good stuff is, right? Most of your sensation, the clitoris, the labia, most of your lubrication. There's also a little internal part of the vulva, the vestibule, which is critical for things like lubrication and comfort during intercourse. And so there are lots of conditions that can affect the vulva. The one that we see most common in our practice is lichen sclerosus, and I know you see that a lot as a dermatologist. So lichen sclerosus is an autoimmune condition that can cause things like itch, absolutely, is a lot of the time a presenting thing, but it also can cause pain and pain with intercourse. In people who are premenopausal, we often see that it causes pain with intercourse before it causes itch. And so when you're looking at patients with lichen sclerosus, like what are you looking for in terms of anatomy, in terms of hallmarks of the disease?
Yeah, I think that there's so much going on with lichen sclerosus right now that I'm so excited to be part of. I agree. Like 60% of my practice are patients with lichen sclerosus. I see a lot of patients with atopic derm and lichen simplex chronicus, but I think lichen sclerosus is something that I really enjoy, doing research on and helping patients with. And so what I do, and I would say that I looked back at my practice of patients, and a lot of patients these days are presenting with more mild clinical signs of disease than say
Mhm.
they did 30 years ago.
Yes.
So I think if you look in the literature, you'll see tons of patients that have, just fusion of their inside lips so that they have very small openings to the vagina.
Mhm.
Maybe they have a smooth clitoral unit as well, with just thick white plaques. And I'd say these days, I still look for that texture change or that
Yes.
little
Like a
wrinkling,
wax
the
paper
fine
crinkling.
white.
Yeah.
Yeah, that's what I look for when I'm diagnosing patients with lichen sclerosus. And so I look at both their clinical signs of disease, that is one of the hallmarks of it for me. And then I look for kind of signs of damage. So, if there are midline labial fusion, changes in anatomy. I check to see if I can retract a patient's clitoral hood. I
Yeah.
look to see if the lips are, the labia minora are, if there's adhesions at the interlabial sulcus as well.
Mhm.
I think the other thing
So
with,
those would be like attachments from one side to the other that cause it to be difficult to open the labia.
yes, but then there's also kind of the, resorption and
Yes, the labia
the
minora to the majora, right?
yes, and so, I mean, in a lot of these patients, that interlabial sulcus is where my eyes go to first. I look to see if
Yes.
there's, linear fissures there, which we can see with a lot of conditions. So we see that with, vulvar candida, you see that with lichen sclerosus, and you can also see it with chronic, irritant or allergic contact dermatitis.
Yeah.
But I think with the LS, you have the texture change, the white pallor, and then I also look for erosions because a lot of patients can have erosive lichen sclerosus that's a lot more, painful for patients, or can be more difficult to get under control.
Yeah.
That's what I look for. And I think it's hard. I think that there are some patients that have comorbid erosive lichen planus. I think that's a lot more common than we give it credit for, but a
Yeah.
lot of patients have signs of LS and LP. And at
Yeah.
least in my hands, those are the ones that take a little bit more to get better.
And I think, when I was trained, I wasn't, there wasn't a lot of information about what to do to reverse some of these changes from LS. And I think now there's much wider acceptance of things like a lysis of adhesions procedure, which can separate any attachments at the midline, right? Like things that are causing change in sexual function because they're closing the opening of the vagina because of the vulvar adhesions. And so now we know that we can actually separate those and make it much more comfortable for patients to have intercourse. And then from a clitoral standpoint, we can actually separate the attachment of the clitoral hood to the clitoris using a pretty pretty low risk procedure and can really improve people's ability to stimulate their clitoris and have orgasm and better sexual function. So I think that's all really hopeful.
Yeah, and I mean, I think the one thing I'll say is, I have tons of patients that um, don't have pain and
Hmm.
can orgasm and still have those anatomy changes. Maybe
Yes.
not with the blind fusion one, but with the clitoral hood. And so
Yes.
I think I'm glad that you guys, are taking care of patients and really making it patient focused, because I think all of these treatments that we could have 8 other sessions about, but they're
Yes.
so patient individualized and so patient focused. But
Yeah.
I mean, there's tons of patients that don't need any procedures, right?
Absolutely. They
And
just
they
need good
find,
control.
yeah, yeah. And so I mean, but every patient is different. And so I think tailoring our treatments and procedures to that patient is huge.
Yes. And tend to use clobetasol for lichen sclerosis, I'm guessing.
I mean, honestly, even with the topical steroids, I tailor it to the disease activity.
Sure, like
So if
how
the
severe
patient
it is.
Yeah, so if the patient doesn't have severe signs of their disease,
Mhm.
but they have maybe severe um, anatomical changes,
Yeah.
then I'll maybe decrease the potency, and I'll follow them and have them come back. But not everyone needs to have an automatic, clobetasol. I think the other thing with the high potency topical steroids is there are many of them. There's augmented betamethasone, there's halobetasol, and there's clobetasol. And depending on the patient's insurance, like some patients insurance won't cover clobetasol, they'll cover halobetasol or something like that.
Sure.
But then in a lot of my premenopausal patients with LS, if they have mild clinical signs, I'll use triamcinolone and they do
Yeah.
very well.
And I
So,
think the nice thing too about using a lower potency corticosteroid is I feel like especially when we're dealing with someone whose symptom is predominantly itch, you can swing them from doing poorly from an autoimmune standpoint and having itch from that problem to having really bad vulvar yeast with high potency steroids. So you have to balance that. And that can
yeah, I
be,
mean, I think the side effects are pretty rare, though. I think as long as, like, I'm sure you guys spend a lot of time talking to patients about how and where to use your steroid. So I
yes,
think as long as patients are given the proper, education about how to use
yeah,
their steroid, these are incredibly safe.
yeah,
And so, I mean, I think that where patients get into trouble and why I think there's a big push from family practice doctors, pharmacists about not using their medicines is patients will come in, they'll show me that they're using 2 weeks of topical steroids, they're slathering it on their inner thighs
yes, a huge
instead of getting
amount.
it,
Yeah.
yeah, instead of getting it right where they need to, on their labia minora, the vestibule, the clitoral
Mhm.
hood, and just using like, a half of a pea or close to a lentil size amount for that whole
Yes.
area.
Yeah.
And so I think that, but then those patients that are using too much, they will have horrible, like, um, increased blood vessels, telangiectasias that can cause
Yes.
more burning, right? So you get this
Yes.
like steroid skin change
Overuse. Yes.
that then we have to like walk them back and kind of really support that itch and burning and pain that happens when you take someone off their topical steroid. So
Right.
I think,
Yeah.
starting from the beginning and giving them a little bit of education about where and how much to use, I think will prevent a lot of those things. Sorry, that's like my soapbox. I
Yeah,
feel
no, absolutely.
I'm sure
I
you do
feel
it
like
too on the
occasionally we
daily
do have
basis.
people who like do well initially on just twice a week clobetasol. Like we can taper them down to not using it that much, but then they sometimes do have itch issues and sometimes they do better on triamcinolone.
100%. Yeah.
Yeah,
And also like a
because they
lot of
have
times
yeast. Yeah.
like, yeah, my LS is flaring, my LS is flaring. And then, I went up to twice a day for the last 3 weeks.
Yes,
It's
and those
actually,
are the people that
right.
get, yeah.
Yeah. And so I'm like,
Yeah.
well, that's why you need to come in and we need to talk
Yeah.
about it
Well,
because
Jill
it might not
Craft
be your
did a
LS.
yeah, she did an LS webinar and she talks about like if you're all of a sudden like red and you were previously doing well and you increase your steroid, then often that's because of either steroid overuse or
Absolutely.
yeast. Yeah. 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 Okay. The other thing I think on the vulva that we do see is vulvar yeast, right? I mean, you mentioned atopic dermatitis and lichen simplex chronicus, and those are more in the itch scratch cycle sort of universe, right? And then there's
Yes, for sure. But they will, I mean, obviously, like with LSC, like a lot of times we don't know why people get it, right? So sometimes
yeah,
infection triggers it, sometimes it's atopy, sometimes it's irritant contact because they're trying to like over clean and then they get
sure.
LSC and then it's just breaking that itch scratch cycle.
Yeah.
Um, And I think a lot of times when, patients will come to me with the right diagnosis and the right medicine, but they're just not using the steroid long enough. They're still waking up at night scratching.
Yeah.
And so for a lot of those patients, I like to treat them with oral medicines to help with the itching. Which ones do you use? What do you do for like LSC for your patients?
Yeah, I mean, we tend to do, I tend to do triamcinolone to try, like if they're in really bad shape to break that itch scratch cycle. And then we'll do, oh my gosh, on the spot, I'm like blanking, but, we'll do oral, like oral antihistamine or,
Like Benadryl or Atarax
the
or
Atarax, there we go.
hydroxyl.
Yeah, just to help with the itching at night, especially because they have some sedating side effects and also affect the histamine pathway. Yeah.
Yeah, I really like, I mean, I think in certain people, the antihistamines work well. But
Mhm.
like you were mentioning, in our first session,
Yeah.
their itch is so complex. And so I like gabapentin a lot for
Yeah.
like Alex chronicus. I actually start at the 100 milligrams just three
It's a
times a day.
night. Yeah.
Um, and then they can titrate up that nighttime portion, but it helps with burning and itching. So I love
Yes.
for vulvar itch. And again, I when it affects the labia majora, that's when I will do the triamcinolone, and I do it twice a day for a month, once a day for a month, and then stop.
Yeah.
And then I'll have the patients come in. But a lot of them that are waking up at night will need that support. And whether it's gabapentin, I also really love duloxetine
Yeah.
for itching and
Yeah.
burning.
It affects the neurologic pathway of itch. Yeah. Yeah. Makes sense.
But if patients are dermatographic, but for instance, so if you draw on their skin and they get like a red wheal or a hive,
Yeah.
the patients that I focus my antihistamines on,
Sure.
like,
Because they have some sort of mast cell component.
yes,
Yeah.
and we know that there's more like mast cells, plasma cells in the vulva. So I do think that there's a lot still that we don't understand about
Yes.
there.
And I think also there's a neurologic component too sometimes. Like I think I've seen people that have comorbid vulvar itch and then they have tender pudendal nerves at their ischial spines. And when we look in their, we'll sometimes do spinal imaging if we can't get them better with topicals, because there are some people who I think have like disc disease in their spine that affect basically they have a radiculopathy that causes itch. And I think that's one of the newer frontiers in terms of understanding the neurologic underpinnings of itch.
Well, I think the other thing, what I mean, and I noticed this myself, like in the middle of the pandemic. I mean, stress and anxiety makes itching and pain worse. And there's been
Yeah.
so many publications on this.
Mhm.
And so I think in a lot of my patients, like, their itching or their flares or whatever gets more severe during stressful times. And
Mhm.
so I really also like just to, talk to the patients, make sure that if they are going through a stressful period, that they have a support system in place, whether it's a
Mhm.
counselor, whether it's mindfulness app or a partner, someone they can talk about
Mhm.
things that can help a lot too. I mean, a
Mhm.
lot of these patients, I'll try to give them a medicine like gabapentin or duloxetine or Lexapro that I'm forgetting the other name. It's a Talibram for their itch or their burning or their pain. And I'll tell them, this is also at a higher dose an antidepressant or a little bit of anti-anxiety medicine, but sometimes all of that goes well together. And so then they'll say, "So you're saying this is crazy, it's all in my head?" And I'm like,
Yeah.
"No."
No,
I'm
definitely not.
telling you from like my own personal experience too, that like a lot of times, when you have itching, especially in the genital area,
Yeah.
incredibly distressing and stressful. And so then
Yes.
that's where that cycle goes, and
Yeah.
you see five different doctors until you get to the right one or someone that can help. And I feel like that's incredibly anxiety provoking too. And so just
Yeah.
making sure that we cover all our bases and help from a lot of different fronts.
Yeah, I usually say like the anxiety causes you to pay more attention to the pathway that started to begin with and reinforces that pathway in your mind so that your brain pays more attention to it. And so we have to kind of modulate that in addition to taking care of what the original problem was.
Yeah, no, I love that. And also, I mean, at night, most people have increased itching at night, right? And that's because at the end of the day, we're laying in bed, we're trying to like, not think of anything. And then that's when kind of the itch creeps up because things are, quiet and we're paying more attention to it.
Absolutely. Yeah. Yeah.
Well, this
Uh,
has been amazing. I've
I
had
know
such
this has been so fun to
a
talk
time
to you.
hanging out and learning with you.
Yes, I really appreciate you doing this. This is so much fun, and I'm sure we'll have other ways to collaborate in the future. But thank you so much.
You're welcome.
All
Yay.
right.